Chapter 35 discusses disorders of the bladder and lower urinary tract. So to begin, we'll talk about kind of the structure of the bladder and some of the different parts. Within the bladder itself, we have the fundus, which is kind of the body, the main body of the bladder, and then the neck, kind of down low where we have the emptying into the posterior urethra. So urine passes from the kidneys to the bladder through the ureters. So here are your ureters right here, and they're connected to your kidneys. The ureters then enter the bladder bilaterally, so on both sides, at a location kind of near the base of the bladder and close to the urethra. So you can kind of see in the dotted lines here that the ureters actually kind of pass behind the bladder and empty kind of lower near actually where the urethra empties out. So all of those things are actually relatively close together. And the trigone is this triangular area that is made up of the two entrances of the ureters as well as the exit of the urethra. So that's that kind of small area that's bound by those two kind of incoming urinary tracts and then the tract that allows us to empty urine from the bladder. So within the wall of the bladder as well, there are several layers. So kind of four layers of the bladder wall. There's the outer, or what we call the serosal layer, kind of out here. It covers the upper surface. It's kind of a meshwork of sort of loose connective tissue, and it's continuous with the peritoneum within the abdominal cavity. The next layer is what we call the detrusor muscle. This is the smooth muscle fibers that allow for expansion and contraction of the bladder. And then there's the submucosal layer that you can kind of see really thin here around the detrusor muscles. It's another area of kind of loose connective tissue, some adipose tissue. And then there's the inner mucosal lining or the transitional epithelium right on that inner lining of the bladder. That epithelial layer acts as a barrier, which is essential because there are different tonicities between urine and the blood. And so without that kind of barrier lining, we would get kind of, osmotic and diffusion kind of related movement of fluid and substances across that lining if there wasn't sort of a barrier of transitional epithelium here. So that is really important to maintaining some fluid and water balance within the bladder. So then we'll talk about the three main levels of neurologic control of bladder function. So neurologic control of bladder function involves the parasympathetic nervous system, the sympathetic nervous system, as well as the somatic nervous system. So we have three levels of neurological control. And the parasympathetic nervous system, which we see kind of represented right here, is responsible for bladder emptying. So for the bladder to empty, we need that parasympathetic nervous system. For the bladder to store or to expand and hold urine, that is the sympathetic nervous system's job to allow additional kind of storage. And the somatic nervous system is responsible for movement of the sphincter. So you can see it kind of here that it is attached to the internal and external sphincters of the bladder. So against parasympathetic control, you can see that here it's directly related to those detrusor muscles. So activation here will stimulate those detrusor muscles to empty. And the sympathetic control you can see kind of come down here to the internal sphincters to kind of, again, hold in urine. So the sympathetic nervous system allows that kind of ability to store urine. So those are all located within the spinal reflex centers. So sacral area of S1 through S4 and thoracolumbar area of T11 through L2. And again, they innervate the detrusor muscles via the pelvic nerve, kind of right here. The pudendal nerve innervates those external sphincters, and the hypogastric nerve innervates the internal sphincters that help to hold in bladder, the urine in the bladder. Okay. You can see both afferent and efferent motor fibers as well as inhibitory fibers, so afferent fibers, meaning those are picking up signals from the bladder and sending them back up. And efferent neurons are sending signals to the bladder itself. Okay. There's also the micturition center that's located in the pons. We'll see that in an image coming up, but that is sort of the sort of relay or control area. So these signals that are coming and going from the bladder itself are relaying through that micturition center. And it kind of coordinates whether or not the bladder is to empty or to further store. And then there are more signals coming from some subcortical and subcortical areas of the brain as well. So the afferent input from the bladder and urethra is carried to the central nervous system by fibers that travel with the parasympathetic, uh, somatic, and sympathetic nerves. Okay. And that's coming from receptors in the bladder wall that are picking up things like stretch. So a little bit more about that micturition center. So the immediate coordination of normal micturition or urinary reflex occurs in that micturition center in the pons. And it's facilitated or helped by descending input. So input coming down from places like the forebrain, also from ascending input from those reflex centers in the spinal cord. So that again, that pons micturition center kind of right here sits between those cerebral kind of forebrain areas and all that spinal cord information, right? So it's receiving signals from the forebrain that kind of come down and is also receiving information through the spinal cord from directly from the bladder, again, for things like stretch, and the center, the micturition center is the coordination center for activity of the detrusor muscles, as well as the external sphincter. So as bladder filling occurs, these ascending spinal afferent nerves relay information to the micturition center, which also receives important descending information from the forebrain. And this includes things like behavioral cues for bladder emptying versus urinary storage. Meaning, is it the right time to urinate, or do we need to hold that urine for a better time? The descending pathways from that pontine micturition center go ahead and produce this kind of coordinated either inhibition or relaxation of the external sphincter. So you can see here, if we are working towards bladder emptying, there's cortical facilitation that says it's time to empty, that comes down from the forebrain to this micturition center. And then that micturition motor function is coordinated there. So we send a signal down for inhibition of the somatic neurons, and that causes relaxation of that external sphincter. And then the other signal is stimulation of the parasympathetic neurons, and they help to cause contraction of those detrusor muscles that leads to overall emptying of the bladder. If we're getting signals of urinary storage, that's here over on the right-hand side, we get cortical inhibition that leads to coordination of bladder storage functions. So we stimulate the sympathetic neurons and they relax the detrusor muscles so they're not contracting. And then we stimulate somatic neurons to contract the external sphincter so that it doesn't open. So again, that's kind of the general sort of neurologic control of bladder function. So again, cortical brain centers inhibit micturition center in the pons and lead to that conscious control of urination. Okay. So with storage and emptying of the bladder, so it again involves both involuntary control from the autonomic nervous system, as well as voluntary control from the somatic nervous system. The parasympathetic nervous system promotes bladder emptying by causing contraction of the detrusor muscles, and the sympathetic nervous system promotes bladder filling by causing inhibition of the detrusor muscles. There's also striated muscles in the external sphincter, as well as in the pelvic floor, that allow for voluntary control of urine. And that's that somatic nervous system um, piece of bladder storage and emptying. The other important piece here is that the bladder remains this kind of low pressure urinary storage. We need the pressure within the bladder to be lower than that of the urethra to be able to maintain storage and to hold that urine in the bladder. There are a lot of different drugs that we can use to either promote emptying or promote storage of urine within the bladder, and they are the drugs that largely work on that autonomic nervous system. So if we use drugs that work on the nicotinic receptors um, of our sympathetic neurons, they usually increase bladder storage. So if we stimulate sympathetic neurons, we're going to increase storage within the bladder. And if we inhibit sympathetic neurons, um, we will increase or, better empty the bladder. This is a table kind of directly from your book that labels the different medications, types of drugs that we can use to aid emptying and or filling of the bladder itself. So this might be a good table to kind of review. A lot of this would be things you discussed in your pharmacology course, but just a little bit of a review here. There are different urinary tests and studies that we can use to look at things like bladder function. So we talked about a lot of laboratory tests already, different urine tests, different serum tests to look at renal function. We can do x-rays as well, but there's also a group of what we call urodynamic studies. Uroflowmetry is a study that measures the speed of flow of the urine itself. We do this through commode-based sensors that directly measure the speed of urine flow. Cystometry is a very helpful urodynamic study. It measures pressures within the bladder. So it can pick up things like, can someone sense when their bladder is getting full? It can look at, can someone contract the detrusor muscles appropriately to either start, or can they contract sphincter muscles enough to inhibit flow? So cystometry is a very helpful urodynamic study for many different bladder disorders. Urethral pressure profile tests the smooth muscles directly in the urethra to make sure that they're maintaining competence to be able to hold urine in the bladder. We can also do ultrasound bladder scans, and this can help us look at something called post-void residual. What we do is just have someone seemingly completely empty their bladder, and then we do an ultrasound study to measure the amount of urine remaining after someone voids. For most people, there should be about 50 cc's of urine remaining. Someone with 200 cc's of urine or greater after they void would be considered to have urinary retention. So then we'll discuss different alterations in bladder functions. Kind of two big categories. One is urinary obstruction, where we get retention and stasis of urine. And then there's urinary incontinence, where we have someone with involuntary loss of urine. A lot of different causes here, but they can be structural changes either to the bladder or to the urethra, or even to surrounding organs that are causing pressure or pushing on the bladder, urethra, or surrounding structures. And then another major cause is any impairment of that complex neurological control of bladder function. So some different signs and symptoms that we see with outflow obstruction and urinary retention. So one big one is bladder distension. As we get urinary retention, the bladder distends, and we can see kind of long-term compensatory and decompensatory changes involved in that. There is a really good discussion in your reading about the different compensatory and decompensatory changes that you should review in this chapter. Another is hesitancy, where someone can sense that they need to empty their bladder, but they aren't able to kind of get a stream going. We also see straining when initiating urination, which might go along with something like hesitancy, where someone actually has to apply kind of downward pressure to initiate that stream. We see a small and or a weak stream. So remember we talked about urofluorometry, which can measure urinary stream. That's one thing we can use to measure whether or not someone has kind of a weak urinary stream. There is frequency where someone needs to use the bathroom much more often. And then they may feel like they're not completely emptying their bladder. And the final thing is something called overflow incontinence. If the pressure within the bladder goes up so significantly because of urinary retention that it exceeds the pressure within the urethra, someone can have involuntary loss of urine or overflow incontinence because of that increased bladder pressure. So let's talk about some common causes of neurogenic bladder or some of the neurological kind of issues that we can see. Stroke and advanced age can play a part here. Parkinson's disease, spinal cord injuries, injury directly to the sacral cord or to the spinal roots, radical pelvic surgeries, diabetic neuropathies, and multiple sclerosis all have a potential to cause neurogenic bladder. You can see in the picture here that these different causes affect a lot of different kind of areas of neurologic control of the bladder. So things like stroke, dementia, tumor, traumas, and multiple sclerosis can directly affect those kind of cortical micturition centers that can either facilitate or inhibit the emptying of the bladder. Things like Parkinson's disease or strokes, and again, multiple sclerosis, can inhibit or damage that kind of micturition center directly in the brain stem. So kind of that control system of bladder emptying and storage. Things like paraplegia, spinal bifida, multiple sclerosis, and tumor can also damage spinal cord injuries that can kind of block some of those messages coming from those upper level control centers of the brain. Direct spinal cord injury or tumors or spina bifida that affect S1 through S4, which is that the sacral root or spinal cord area, affect kind of the reflex centers that help control urination. And things like childbirth or straining with stool, like in the case of constipation, diabetic neuropathies, pelvic surgeries, can damage the afferent sensory nerves that are sending signals from the bladder back to the spinal cord that should end up in that micturition center. So again, kind of looking at all the different causes and the kind of effects that we'll see or the type of neurogenic bladder that we might see will vary based on where these different effects occur within that neurological control. So one major type of neurogenic bladder disorder are the spastic bladder dysfunction. These are failures to store urine. So if we're talking about kind of what's coming from that kind of forebrain down to the micturition center, that's responsible for, remember, either inhibition or stimulation of that signal to urinate. And so if we have a spinal cord injury or a neurological lesion or something kind of above the level of that sacral cord, so something kind of higher up within the spinal cord, that blocks neurons from the micturition center from kind of coming down to um, the bladder itself. So neurological lesions above the level of the sacral cord, so that S1 through S4, allow neurons in the micturition center to function reflexively without control from the CNS centers. So again, any of those kind of signals that would be coming down or any signals coming up are blocked by that lesion here. And so the only signals that we're getting are those reflexive signals from S1 and S4. And if you remember kind of back to our beginning kind of conversation, that's where that parasympathetic kind of control is mainly coming from. And that parasympathetic control is stimulating the detrusor muscles to squeeze and empty. But now we've lost any of the inhibitory kind of things that would signal the SNS to relax the bladder, so that's not happening. And we've also lost that kind of somatic control of the external sphincters. So without those two things, either the quieting of the detrusor muscles from the SNS or the contraction of those sphincters, all we have left is that kind of parasympathetic, constant sort of signal from the parasympathetic nervous to squeeze the detrusor muscles. And that's why we have spastic bladder. So all we get is that constant squeezing and involuntary loss of urine. The other major category of neurogenic bladder disorders are the flaccid bladder dysfunction. This is when the bladder cannot empty. So these are usually seen in neurologic disorders that affect motor neurons in the sacral cord or peripheral nerves that control detrusor muscle contraction and bladder emptying. So you can kind of see that in my picture here. I've got the brain and spinal cord, everything is intact all the way kind of down. But now we've got a lesion right here, kind of in those motor neurons and in the sacral cord itself. And so we don't have the parasympathetic nervous system innervation to be able to um, uh, squeeze the bladder or to stimulate those detrusor muscles. And we've also lost some of that control of the sphincter muscles as well to kind of open and empty. And so that bladder just continues to fill and would be unable to empty at that point. So those muscles are kind of completely unable to sort of work. Those muscles over time will start to kind of atrophy because they aren't being innervated, further leading to issues with emptying the bladder. So the goals of treatment for someone with neurogenic bladder, number one is to prevent any bladder overdistension. So especially someone with flaccid bladder syndrome, we don't want that bladder to continuously be overdistended. We also want to prevent any urinary tract infections, especially with stasis of urinary flow. We want to prevent any potentially life-threatening renal damage, so severe urinary distension that would back up into the kidneys, causing severe hydronephrosis and post-renal kidney disease. And we also want to help reduce the undesirable social and psychological effects of this disorder, either from things like spastic bladder that would cause constant emptying of the bladder, or from flaccid bladder, which might cause things like overflow incontinence. All of these need to be managed. So we do have some treatments for neurogenic bladder. Some patients will need to catheterize. Some may even need to self-catheterize, long term, especially for flaccid bladder disorders. We can potentially do some bladder retraining where we put someone on a kind of urinary schedule in an attempt to sort of get that full stretch and then contraction sort of relearned in our patient. We can use different pharmacological manipulation. So things like muscle relaxants might help to reduce sphincter tone. Antimuscarinic agents can decrease muscle tone in patients with spastic bladder, leading to an increased storage capacity. Cholinergic agents can increase detrusor muscle tone and help to stimulate emptying of the bladder. Surgical interventions can be things like urinary diversions, like we talked about in class. We can try to surgically fix sphincters, or we can remove nerves that are causing that kind of overall urinary spasticity. So then we'll move on to incontinence. So lots of different types of incontinence. Stress incontinence is one major category. This involves involuntary loss of urine when someone's intra-abdominal pressure increases. So these are during times of maybe coughing, laughing, sneezing, or lifting. Stress incontinence is usually associated with people who have maybe weakened like pelvic floor muscles. The pelvic floor is essential to helping us have voluntary control of the release of urine. And so if those muscles become weakened through things like childbirth or sedentary lifestyle, that's what typically leads to things like stress incontinence. Urge incontinence is an involuntary loss of urine associated with a strong desire to void. So in this, there's usually something going on with maybe increased sensation of having to void that's so strong that someone can't kind of overcome that sense of urgency to void, and they might have involuntary leakage of urine. Other types are overflow incontinence. This is when we have an involuntary loss of urine because of an increase in intravesicular or intrabladder pressure that exceeds the maximal urethral pressure. So this is usually because the bladder has become so distended because of a loss of detrusor muscle activity that that pressure rises so much that urine actually leaks out through that now lower pressure urethra. And then we can also have mixed incontinence, where we have combinations of stress and urge incontinence as kind of one of the most common types. So treatment options, typically management depends on the type of incontinence. So it's really important to understand what type of incontinence your patient is experiencing because the treatments that you recommend will be different. We also have to look at accompanying health problems as well as the person's overall age when we're managing these. So again, we have behavioral and pharmacological measures. So if maybe we have someone with something like a maybe an urge incontinence, we might give a medication to sort of um, oh, I don't know, maybe reduce detrusor muscle activity. So maybe some sort of sympathetic stimulation or parasympathetic block medication might help with that. Um, Someone with urge incontinence, we may also do some bladder retaining therapy. Someone with maybe stress incontinence, we may do kind of Kegel exercises or pelvic floor strengthening exercises. Those might be very helpful. We can do surgical correction, so things of the pelvic floor um, might be a surgical kind of piece. Um, there are some non-catheter devices that can obstruct urinary flow and or collect urine that might be helpful, especially for maybe people with overflow incontinence or urge incontinence. In some cases, we may need to use an indwelling catheter, maybe with a leg bag for a patient, or self-catheterization, especially for those maybe with overflow incontinence. Incontinence is rather common in elderly populations. Lots of different reasons for this. One is that the overall capacity of our bladder reduces with age. And we also see a decrease in urethral closing pressure as patients age. And so it doesn't take as much pressure within the bladder to overcome urethral pressures. So that makes incontinence more common. Detrusor muscle function also declines with age. So that kind of ability for those detrusor muscles to contract and empty. And this leads to larger post-void residual volumes. We also see restricted mobility with advancing age. So that can lead to something called functional incontinence, where someone can't maybe get to the bathroom in time, and so they have incontinence related to that. They take more medications in elderly populations, and so you might have more medication influence on bladder function. There's also comorbid illnesses that can affect bladder function, higher rates of infections like UTIs, and also stool impaction, which can affect kind of the sensory inputs and things largely from the bladder that can lead to incontinence. Finally, we'll talk about bladder cancers. So, some signs of bladder cancers: increased frequency of urination, increased urgency to urinate, dysuria or painful urination, as well as hematuria or blood in the urine are common signs of bladder cancer. There are different lesion types and stages. Stage 0 would be a cancer that's just in that bladder lining, or with maybe slightly into the connective tissue. Stage 1, we're a little further into the connective tissue, maybe down into the muscle. Stage 2, kind of deeper even into the muscle. Stage 3, all the way up to just about that kind of loose connective tissue on the outside. And stage 4, kind of all the way through the layers of the bladder. At stage 3 and 4, we would also see lymph node involvement. And then at stage 4, we would see travel to distant kind of organs and tissues. So diagnostic measures for cancer of the bladder, different cytological studies that we discussed earlier, different urometry studies, cystoscopy is helpful. If we find lesions, biopsying to determine the type of lesion, CT scans and MRIs to determine staging of these lesions to see if we have any spread beyond the bladder itself. So treatment methods depend on the cytology and the grade of the tumor. So remember when we do cytology, we're looking at the type of tumor that's there, the type of tissue, and so that determines some of the treatment. And then also the lesion's degree of invasiveness. How far through the bladder wall has this lesion traveled, and is there any sort of metastasis of that tumor? Methods for treatment include surgical removal of the tumor. And then, what's left behind of the bladder will really depend again on the degree of invasiveness of that lesion. We can also use radiation and chemotherapy, just like with any other type of cancer.